abdominal region, we can make it as LMS. Okay, most common intra-abdominal sarcoma is going to be your LMS only, because it constitutes around 0.5% of all fibroids, which is quite a huge number throughout the world. Whereas if you take up GIST is going to be only about, GIST constitutes only about probably 5,000 cases totally in the United States. So all put together, the number is not going to be that great, but GIST is going to be the most common GI sarcoma. So GIST is going to be the most common GI sarcoma. But as far as the bone tumors are concerned, as far as other intra-abdominal sarcomas, if the question comes, then the answer is going to be leiomyosarcoma. Though in some areas in DeVita, it is, in Sebastian also it's managed differently. But I think the answer, if LMS is given, you should mark LMS as the most common intra-abdominal sarcoma. Okay, right. So then the question goes on to, the management goes on to bony tumors. Now, bone tumors, they can be classified as the primary bony tumors, secondary bony tumors, like that. Now, we know that secondaries are more common than primaries. Now, among the secondaries that happen in the bone secondaries are, this is an often repeated question, the most common site of bone secondary, the primary site is going to be from the breast. Second is going to be prostate. So if the question comes as in males, then you can mark it as prostate. Only if it comes as males, then you can mark it as prostate. Otherwise, you can mark it as breast. Breast is going to be the most common overall for getting bony secondaries. Now, among the primary bony tumors, you will again get myelomas, which are going to be very common. That is the most common primary bony malignancy. Among the primary bony sarcomas, you will get your osteosarcoma, that is your primary sarcoma. Okay, so that is the order in which things will go. Right, now going on to some MCQs. So identify the wrong statement. Osteoblasts are surrounded by mineralized collagen matrix, osteoid matrix. Osteoclasts are derived from the hematopoietic stem lineage. Circulating stem cells with CXCR4 receptors are recruited by the bone marrow with the CXCL12 chemokine. And tumor cells can directly stimulate osteoblasts to generate the Rankel ligand, which is the most prominent cytokine inducer of osteoclastogenesis. Now, when these kind of questions come, generally it's a little difficult for you to identify, but this one is actually pretty clear if you know some of the basics of bone cells. So you've got three types of bone cells, which is going to be your osteocytes, you've got your osteoblasts, and then you got your osteoclasts. Okay, so the most important bone matrix secreting cells are the osteoblasts. Okay, so these will secrete the bony matrix. Okay, this osteoid matrix, as we call it, will be secreted from the osteoblast, and then these cells will be surrounded by the bony matrix completely, and they will lose the secreting ability. That is when they will become the osteocytes. Whenever the bone cells become inactive, the osteoblasts become inactive, that is when they will become osteocytes. So here the wrong answer is osteoblasts are surrounded by a mineralized collagen osteoid matrix. So it's the osteocytes that are surrounded, not the osteoblasts. Then you have your osteoclasts. Osteoclasts are supposed to be from the blood cells lineage, from the monophil macrophage system. So they generate this, they are stimulated by this Rankel ligand. So which is the important, why is the importance of Rankel ligand is because of the drug called as denosumab. Okay, now denosumab is an anti-Rankel monoclonal antibody. Okay, denosumab, if you look at it, is an anti-Rankel monoclonal antibody. This anti-Rankel monoclonal antibody is going to be your denosumab. So whenever you consider any kind of bony metastasis, there will be an activation of osteoclasts. Osteoclastogenesis is going to happen. This is happening mainly based on the action of Rankel. So this has to be inhibited by this drug called denosumab. It is useful in a certain of the primary tumors as well. It is useful in few of the primary bony tumors as well. But that is why for this particular question, the answer is osteocytes. It is not the osteoblasts, it's the osteocytes which are going to be surrounded by the collagen matrix. So as I already mentioned, yes, so it is osteocytes which are differentiated mesenchymal stem cells. Osteoblasts are the differentiated mesenchymal stem cells that secrete the matrix. Then they become converted into osteocytes when they are surrounded by the mature bony matrix. Osteoclasts resorb the bone. They are under the influence of the CXCR4 receptor and this particular CXCL12 chemokine, and They are under the influence of the rankle. Rank is the receptor and rankle is the ligand. And so that is a decoy receptor. Now, what is the function of osteoblasts? It is to make sure that the bone remains healthy. So they will secrete something called as osteoprotegerin. Okay, so the osteoprotegerin is a decoy receptor which is secreted by this one, which will inhibit your rankle ligand. So it inhibits osteoclastogenesis. It's an anti-rankle inhibitor, basically. So osteoprotegerin is basically, you can take it as a natural form of the denosumab, which is happening. Now, the mechanism of action of osteoclasts is by the GTPase enzyme. So they decrease the resorption and bisphosphonates, basically. Bisphosphonates will inhibit the GTPase. That is where it will act. And the preferred agent among the bisphosphonates, if the answer comes, this has been a question right from the time that I have been writing my exams. Among the bisphosphonates, which is the preferred one, the answer is going to be zoledronic acid. In bisphosphonates, which is the preferred one, the answer is going to be zoledronic acid. In bisphosphonates, the preferred agent is going to be zoledronic acid. There are, of course, some orally available drugs now, like ibandronate, like flodronate. All these are available orally also. So some of the oncologists have started preferring these drugs, but then still the treatment of choice for any kind of skeletal related events, whenever the patient has got bony metastasis, remains to be zoledronic acid. So denosumab, the brand name, one of the commonly used ones is Xgeva. There are multiple brand names. So it is an anti-rankle monoclonal antibody. The best effect is produced in reducing SRE. So what do you mean by SRE? SRE means skeletal related events. So any kind of bony pain, fracture, dislocation, whatever happens in relation to a metastasis. So this kind of skeletal related events that happen in terms of metastasis, the best drug of choice for them is going to be denosumab. So if you ask which is the preferred drug of choice for managing or reducing the skeletal metastasis or skeletal metastasis related events, it does not prevent the skeletal metastasis, it prevents the events associated with them. The drug of choice is going to be denosumab. The drug of choice is going to be denosumab, which is going to be the first drug. But the most economical, because sometimes they may ask you questions with regard to that. If they ask you which is the most economical drug which can be used, in that case, the answer is going to be your Zometa or zoledronic acid. Then it is going to be your zoledronic acid, which will be the preferred agent in case it is asked as most economical, right? Now, this is how the mechanism will be happening. So this is going to be your osteoblasts, which are going to secrete your osteoprotegerin also, which will inhibit the function. So the rankle here is inhibited by this osteoprotegerin, and this is going to be your osteoclasts, which are going to get differentiated, forming osteoclasts and then getting stimulated by rankle. This is the rankle receptor. And denosumab is also same thing. If you look at it, both of these fall under the same group. Osteoprotegerin and your denosumab, both of them fall under the same group. So here, what will happen? The metastasis, once it goes, it homes in. So this circulating tumor cells, which are going to have the ligands. So they will have the ligands that will go and bind to particular sites, and that is how they are going to act on the particular site of bony metastasis. Now, with regard to any kind of bony tumor, we have to talk about the primary bone in question. We have to talk about the site inside the bone, as in like which bone is involved. Is it the femur? Is it going to be the tibia? Is it the spine? Is it the phalanges? So that is going to be of great use or great importance in designating what kind of tumor it's likely to be. Second is in the zone of the bone. Okay. So whether the tumor is going to be found in the epiphysis, whether it is found in the metaphysis, whether it is found in the diaphysis. So these are some things that are going to be important. And then you have to look at the radiology. The X-ray picture of the patient is equally important. Now, in deciding the pathology inside the bone, all these three things will be important. For example, when we talk about the primary in the bone, when you have a chondroid lesion, when we have a chondroid lesion in the bone, now this chondroid lesion can be what I can say is basically something that in chondroid lesion in the phalanx, for example, in the phalanx will be considered to be a benign lesion. On the other hand, the same lesion which will be found in the pelvis, the same lesion which can be found in the pelvis will be labeled as a chondrosarcoma. Pathology-wise, both of them may look similar, but the location of the lesion in which part of the body will determine what is going to be the diagnosis. And again, the radiology is equally important. There are various appearances. There is going to be a musculoskeletal tumor staging classification where they classify it as 1, 2A, 1A, 1B, whether it is going to be moth-eaten appearance, whether it is going to be your geographic appearance. So this kind of lytic lesion, non-lytic lesion, like that they will be describing. So there is a classification for that based on the X-ray features. They won't ask you in the exams. I'm just telling this to you for your identification and knowing that there are a lot of lesions, and the pathology as far as bone sarcomas is concerned is a complex pathology. It is not something simpler. For example, whenever you got a lesion like this, put it a little more clearly. Whenever you got a lesion like this in a cutaneous tumor, what is going to be the answer? Here we are definitely going to talk about a keratin pearl. And so the answer is going to be, it is the squamous cell carcinoma of some sort. Okay, so wherever it is, have the keratin formation that happens, it's always a squamous cell carcinoma. Whereas this kind of picture may not be always present as far as a bony tumor is concerned. Some tumors do have it. For example, an Ewing sarcoma and PNET will have a clear feature of your small blue round cell tumor. The SPRC group or the small blue round cell tumor group will be having it. So like that, there are some, but it is not always very clear as far as the bony sarcomas are concerned. So the location of the lesion, the type of appearance, and the description that is going to be pattern, all this is going to have an impact on deciding on the pathology of the lesion. That is something that we have to remember. Now, identify the incorrect match with regard to bone tumors and the location. Right. So this is the common thing. Most of you will be knowing about this. So, when we talk about your lesions, epiphysis, metaphysis, and diaphysis. So the metaphyseal lesion is going to be the most common. All bony lesions, the metaphysis is going to be the area where it will be having it commonly. Now, on the other hand, epiphysis, whenever we talk about it, is chondrosarcoma correct, which is the incorrect match which is mentioned here. Diaphysis, osteoblastoma. Intracortical metastasis happens in lung carcinoma, and tibia with a chondromyxoid fibroma. Which of this is an incorrect match? The answer to this question is epiphysis with chondrosarcoma. Remember, don't try to remember the metaphyseal lesions. Almost everything will happen in the metaphysis. As I said, in the metaphysis, most lesions will happen in the metaphysis, including the osteosarcoma, metastasis, infections, everything commonly will be present in the metaphysis. Now, what is this, metaphysis, diaphysis, and epiphysis? For people who don't remember the basics of orthopedics, now this is the physis or the end plate. Okay, so this is going to be the end cartilaginous plate. Now, any tumor that happens above this, above the end plate, that region which is known as the epiphysis, above the physis. Physis stands for the growth plate. Now, above the physis is known as the epiphysis. The characteristic example of an epiphyseal tumor is your giant cell tumor. There are only few tumors that will happen in the epiphysis and diaphysis. So try and remember them. Then it will become easy. Rest of it will come in the metaphysis. So in the epiphysis, the classical benign tumor, locally aggressive tumor is going to be your giant cell tumor. And then you have your chondroblastoma, which is also going to be present in your epiphysis. Other than that, there is one variety of chondrosarcoma called as clear cell chondrosarcoma. So giant cell tumor, clear cell chondrosarcoma, and chondroblastoma, these are the things that will be characteristically present in the epiphysis. The same way, whenever we talk about diaphysis, the classical one is going to be your Ewing sarcoma and osteoblastoma / osteoblastoma. Also your adamantinoma and fibrous dysplasia. Okay, so these are the things that will happen here. Okay, so remember this particular thing. The rest of it is going to be very simple for you. And again, location-wise, tibia bone is the site for chondromyxoid fibroma, and acral and intracortical metastasis. They may give you a lesion which is there in the metatarsal bone. Okay, in the metatarsal, you will get a lytic lesion like this. So that is going to be characteristic of your lung carcinoma. Small bones, you will get the kind of lytic lesions in the metatarsals and things like that, either in the foot or in the hand. That kind of presentation is common with the metastatic lung carcinoma. So again, tibia is the site for chondromyxoid fibroma. So these are some clues to the diagnosis. So whenever we talk about epiphysis, 3 lesions: giant cell tumor, clear cell chondrosarcoma, and the chondroblastoma. As far as diaphysis is concerned, the major thing that you have to remember is going to be your Ewing sarcoma, adamantinoma, osteoid osteoma / osteoblastoma. both of them basically mean the same thing. And then your fibrous dysplasia. So these are the things that are happening in these areas. So remember the epiphysis, remember the diaphysis, and rest of it is then going to become easy for you. Okay, so rest of it will then become easy for you, right? Yeah, now going on to some of the other MCQs, which is the most common bony malignancy. So is it breast metastasis, osteosarcoma, myeloma, or prostate metastasis? This is what I was alluding to when I started the introduction for the class. Among the malignancies, we know that secondaries are going to be common. So metastasis is the one. So is it breast or prostate? As I already told you, breast is the most common primary from which bony metastasis happen. So the answer is going to be bony metastasis from the primary in the breast. So it's a breast metastasis. So bony malignancies, the primary most common is going to be breast. Most common primary in the males, if the question comes, then it is going to be prostate. So some examiner may ask you which is the most common, cause of bony metastasis in males. So then the answer will be prostate. Now, among the primary bony malignancies, I think there will be a question that will come for that. Yeah. Next question is, okay, we know that bone metastasis are common. Which is the most common site of bone metastasis? So here the answer is again spine. Okay, so here the answer is going to be again the spine. And in the spine, which is the most common site, the answer is going to be again the lumbar spine. Okay, the lumbar spine is the most common site of secondaries to the bone. The lumbar spine is going to be the most common site of secondaries to the bone because of the Bateson's plexus. Okay, because of the Bateson's plexus of blood vessels that will surround the spine. So that is the reason it is highest in the lumbar spine area. So lumbar spine is the most common site of bony metastasis among the bones that are involved. Okay, right. Which is the most common primary bony malignancy? Now that we have excluded metastasis, which is the most common primary bony malignancy? As I already told you, it is a myeloma. If they ask you which is the most common sarcoma, then the answer is going to be your osteosarcoma. On the other hand, primary bony malignancy is going to be your myeloma. So which is the most common cause of bony metastasis in children? That may be one question that we ask. So here the answer is going to be your neuroblastoma. So here the answer is going to be your neuroblastoma. So in children, the answer is going to be neuroblastoma. You will get that blue worry muffin sign, multiple areas of skull, other areas of metastasis. All this will happen in young children in neuroblastoma, which is very classical. So in the bony tumors, bone, when you look at it after lung and liver, this will be the third most common site of metastasis after the lung and the liver. So most of them are secondaries arising from the breast, followed by prostate, then lung, and then others like renal cell carcinoma, thyroid. All these can also come. And among all the metastasis, most of them are going to be lytic, except the prostate, which is going to have your blastic or sclerotic metastasis. So the question may be asked, which is the most common cause of sclerotic metastasis? So in that case, the answer will be prostate. So sclerotic metastasis will happen in prostate. All other sites will be the sites of lytic metastasis. So in bony metastasis, spine, because of the Bateson plexus, the second most can be asked. Then it is the femur, proximal femur, and proximal humerus. These are the site. So first is going to be your spine, which is your lumbar spine. Then second one is going to be your proximal femur. Third is going to be your proximal humerus. And finally, you will have your thoracic spine. Only then you will get your thoracic spine. So there is some question, some confusion as to regard to breast going on to the thoracic spine as metastasis. But remember, first is the lumbar spine metastasis, then your proximal femur, and then you have your proximal humerus, and finally you have your thoracic spine. That is the order in which it will come. Primary bony malignancy is myeloma, which is basically your multiple myeloma. The solitary form of this lesion is called as plasmacytoma. And then you have your primary bony sarcoma, which is osteosarcoma. Secondary osteosarcoma will happen in Paget's disease in elderly. When we talk about osteosarcoma, it will have a bimodal age distribution. Bimodal age, one is going to be in the teens and the other one is going to be in the elderly age group. In the teens, it will be a primary osteosarcoma. Here it will be a secondary osteosarcoma, which is usually as a consequence of your Paget's disease of the bone. So, or it can be radiation-induced sarcomas as well. as far as elderly age group is concerned. And in children, the answer is going to be neuroblastoma. Second is going to be your RMS, right? Now, considers conditions that are associated with an increased risk for developing malignant disease in the bone and the cartilage. Here we have the multiple enchondromas. So in multiple enchondromas, we have your, that is also known as your Ollius disease. So multiple enchondromatosis or Ollius disease. And the same thing, if it is associated with soft tissue angiomas, then you call it as Maffucci syndrome. So both the syndromes are associated with an increased risk of developing sarcomas, okay, bony sarcomas, enchondromas, multiple enchondromas, and those that are associated with your angiomas of the soft tissues as well. Both of them are associated with high risk of developing bony disease. And of course, we have your retinoblastoma, which is associated with a high risk of osteosarcoma. Then we have your P53 mutations, your Lee-Fraumeni syndrome, which is also associated with a high risk of developing soft tissue sarcomas, including and bony sarcomas like osteosarcoma as well. So hereditary multiple exostosis. Now remember, chondrosarcomas are more common. Multiple enchondromatosis is most common as the cause. Then you have your hereditary multiple exostosis as a cause. Then you have polyostotic disease and radiation-induced osteitis. All these three will come under the moderate risk category. And low risk is sometimes they are associated with osteomyelitis, osteoid necrosis, osteogenesis imperfecta, osteoblastoma. All these are considered to be low risk for developing your bony metastasis. So again, this is the classification of epiphysis, metaphysis, diaphysis. As you already mentioned, in diaphysis, remember Ewing sarcoma, osteoblastoma, fibrous dysplasia, and adamantioma. And in epiphysis, remember the giant cell tumor, and then you remember your chondroblastoma, and then you remember your intraosseous ganglion and your clear cell chondrosarcoma. That particular variety called as clear cell chondrosarcoma, that is also common there. So again, this is very clearly, beautifully given, which is the metaphyseal area, which is the epiphyseal, and which is going to be the diaphyseal area. This diagram gives it to you very beautifully. It has outlined the areas and the tumors which are associated with it. So here you can see that there is a fracture which is associated with the core biopsy, and after that, that is the reason why you should not do a core biopsy. Whenever you have metastasis, you should not go through the cortex. The approach is through the greater trochanter. Here we can see the nidus of the lesion. So through the greater trochanter, transtrochanteric approach is the approach which will be preferred for the doing a biopsy. That may be a question that may be asked for you. So based on Sebastian and Bailey itself, so it has to be through the greater trochanter. And again, intramedullary nail is also the place where it can be inserted. So after doing a biopsy and confirming it, you can also put a nail to stabilize it through the same approach. Through the intramedullary fixation, you can do that as well. And that is why that is the preferred approach that you have. Right. Now, site-wise, we have already mentioned about osteoid osteoma, Ewing sarcoma for diaphysis, epiphysis. All this we already had a discussion. Yeah. Now going on to the age. Now in adults, we know if it is teenagers, Ewing sarcoma. Now this is for diaphyseal tumors. When we talk about it, Ewing sarcoma, but this is common in the teenage group and in young children. Very young children, less than 10 years, you have to consider eosinophilic granuloma as one of the diagnoses. And if you get a diaphyseal lesion in elderly age group, then you have to think of metastasis or you have to think of myeloma. So these are the things that will be found. Now, simple bone cyst will also happen in the proximal end of the long bones of children. Okay, simple bone cyst will happen in the proximal end of long bones of children. Right. Now, whenever you have a lesion in the bone, what is the first investigation? The first investigation is an X-ray of the particular bone, and always compare it with the opposite side. And that is needed to characterize the lesion. And you have got the type 1, type 2A, B, and then you have got the type 3 lesions like this. You have got a classification for the X-rays based on whether it's a geographic pattern, moth-eaten pattern, whether it's going to be a sclerotic pattern. So many patterns are there. So based on that pattern, we have to make a differential on what kind of lesion it is. So X-ray is the most important thing to make the diagnosis. And image the whole bone. Just don't take one end of the bone. You have to image the whole bone, and always it should be bilateral as well. That is another point that you have to remember. Though it's not mentioned here, it has to be bilateral to compare it with the opposite side to find out the subtle abnormalities which may not be visible on a unilateral thing. Unless you notice it with the opposite side, you may not be seeing it. Now, whether through an MRI or whether through a CT, remember both of them are usually complementary. CT will give you better resolution for the cortex. As we already saw in the head and neck part, CT will give you better resolution for the cortex, and MRI will show you better resolution for your soft tissue. MRI will give you a better soft tissue delineation. Vascular reconstruction, that will be better done with an MRI. So all these can be better done with an MRI, but when you take up the CT, cortex invasion is better made out on a CT. And whole body bone scan. So whenever you have lesions like this, to look for skip metastasis, you have to look for the whole body bone scan to look for skip metastasis. And a CT just always has to be done to rule out the lung metastasis. Calcium, C-reactive protein, alkaline phosphatase, all these are routinely prescribed by this one, and some of them will include the PTH values also in the measurement, especially in case of lytic lesions, whether to do serum PTH and vitamin D levels. That is all something that will be done by the orthopedicians as a part of the routine, along with the other investigations as well. But remember, the first investigation is going to be an X-ray, and the local imaging will be in the form of an MRI or a CT scan, and the whole body bone scan along with CT test is also required when you want to stage the bony sarcomas. As is the principle, whenever we talk about biopsies, it is only after imaging. First step is to do an imaging, and then after you finish your CT, MRI, etc., then you have to plan a biopsy. The needle which is used is known as a G needle or a Jamshidi needle. That is your classical bone marrow needle, something similar to your bone marrow needle for bone biopsies. Also, the same needle will be used. So this is your Jamshidi or your JAME needle, which I have circled here as the green thing there. Now, similar principles to what we have for soft tissue sarcomas. The biopsy incision should be along the line of the future incision, longitudinal. No drain should be placed. Do not raise flaps. Cross-contamination of compartments. Avoid damaging vital structures. Essentially, the same biopsy principles as what we discussed before. Essentially, the same biopsy principles as what we discussed before will apply even for the bony sarcomas as well. The only thing is we have to remember that we have to do a biopsy in the shortest route. Okay. Generally prefer to use the shortest route or along the pathway that we will be planning for it. Okay, right. Now going on to the grade and the stage of the lesions. Grade and the stage of the lesions. Now, Musculoskeletal Tumor Society gave a Enneking staging system. Now, this Enneking staging system is applicable to both your benign tumor staging and your aggressive tumor staging. Now, for your benign tumors, you have a lesion which is latent. Now, latent is a tumor which is present completely inside the bone. This is for the benign tumors. Remember, my friend, this is the Enneking's benign tumor staging. So where you have a lesion which is completely inside the bone, the cortex is maintained. You can see here that the cortex is maintained. The second one is an active disease where you have an increase in the growth, and there is not a breach of the cortex, but it remains intracapsular. But you can see that it is getting bulged out like this. And the third one is something called as an aggressive disease where it is breaching it is not limited by the capsule or natural boundaries, where it is breaching the boundary. So this is known as your aggressive lesions. Classically, this will apply to the GCT, giant cell tumor. So benign tumor is going to be, one is your latent, then you have your active stage, and then you have your aggressive stage. So latent, active, and your aggressive, 3 stages are there as far as the Enneking's tumor classification for your benign tumors is concerned. Now, MSTS staging, or the same Enneking staging as far as your sarcomas, that is your malignant bony tumors are concerned, it is very simple. Grade, low grade is skeletal sarcoma is stage 1, high grade is stage 2, and metastatic disease is considered to be stage 3. Very, very simple classification. Low grade, high grade, and metastatic. And in this, you have your A and B, which is intracompartmental and extracompartmental. This is your Enneking staging. Now, there is another staging, which is the classical AJCC staging, which will be similar. Only thing is here it is low grade, high grade, then 3 becomes your skip metastasis. That is the only difference between the stage, and 4 is considered to be distant metastasis. They have basically made it as 1, 2, 3, and 4. So 1, 2, 3, and 4. 4 is of course your distant metastasis. 1 is going to be your low grade tumors. 2 is going to be your high grade tumor sarcomas, and 3 is going to be your skip metastasis. This is a specific thing, especially if you find an osteosarcoma. Suppose you have got a lesion here in the head of the femur. Sorry, that's a poor drawing. I'm not able to access my iPad properly. But anyway, this is the head, and you have got a lesion somewhere in the distal femur. Let's say you have got a lesion which is sitting here in the distal femur commonly, and then you have another lesion which is sitting here. This kind of lesion is called as a skip metastasis. Now, this skip lesion will make it a stage 3 disease. And of course, you have your stage 4, which is going to be your distant metastasis. And in all this size less than or equal to 8 centimeters and more than 8 centimeters will make it a or B. Okay, so low grade A means less than 8. More than 8 will make it a B staging. This is your sarcoma staging as far as bony sarcomas are concerned, relatively easier to define. So then going on to the genetics of bony sarcoma, which is the wrong match here. I'm not sure that many of you will be familiar with it, but some of them you'll be knowing. So EWS-IFL1. Remember, please change this, my friend. This is EWS, not ESW. That was the typo. That is EWS bar FLA1. That is the most common translocation. This T1122 translocation, as we call it. We already had a word regarding this T1122 translocation in your soft tissue sarcoma. This is the most common translocation that you will find in Ewing sarcoma, EWS and FLA1. That is going to be the one. Now, osteochondroma or exostosis, okay, or exostosis is associated with X1 and X2. That is the reason why the genes are named as X1 and X2. So that is also going to be true. So the false option here is going to be your IHH and PTH-RP that is not found in your giant cell tumor. So giant cell tumor, you will actually find the Rankel ligand fusions. You will find your Rankel ligand fusions, which are going to be more common, whereas your enchondroma is the one which is associated with the Indian hedgehog pathway and PTH-RP receptor. Okay, so translocations, if you look at it, Ewing's FLA1, that is T1122 translocation, and 2122 as EWS and ERG, that is the common thing that will be found here. And then you have your aneurysmal bone cells, unlikely to be asked. Giant cell tumor, they may ask you for the telomeric fusion, which you will have. So TPX2 and Rankel, that fusion you will find it in your giant cell tumor. Now, my friends, I understand that remembering all of this is a pretty tough one to do, but I will ask you to remember only the common or what is likely to come in your exams. So that is why I am highlighting this. You know, T1122 is a common one. Then Rankel related, they may ask you in relation to your giant cell tumor because it has got an implication in your staging. Osteochondroma, the other name is exostosis, so easy to remember X1, X2, and your X3. And chondrosarcoma, IDH1 and 2. This is important. Why? Because you now have IDH inhibitors which are coming up, so that may come as a question. And this is the same thing which is also seen in your gliomas and glioblastomas as well, along with AML, hepatobiliary tumors. Many of these you have the role of IDH. IDH is basically your isocitrate dehydrogenase. Isocitrate dehydrogenase pathway. So you will find just like you have your SDH when we were talking about sarcomas, no SDH and just multifunctional. Familial GIST when we are talking about SDHB, especially mutations and just something similar to that. IDH mutations will be found in your chondrosarcoma. Enchondroma is associated with PTH-RP and the Indian hedgehog pathway. Fibrous dysplasia, they are unlikely to ask you. All this is mentioned in Sebastian. I have just highlighted the important ones for you. Right. These kind of clinical questions are asked quite a bit in your examinations. So you've got a lady here who's 57 years old. She has a lesion in the right proximal humerus. Identify the lesion and the management of this particular lesion. Now, you look at this. First thing you have to classify is what are the lesions which are mentioned here. They are mentioned osteoid osteoma, giant cell tumor, osteochondroma, and your enchondroma. Now, what are the likely diagnoses that you already know about? Now, osteochondroma, you already know is your exostosis. Now, exostosis, how will it look? It will be like this. And from the tumor, from near the metaphyseal end, you will have the kind of like a projectile tumor like this. Does it look like that? No. So, it is not likely to be your osteochondroma. Now, osteoid osteoma, as we already saw, it is going to be something which will be usually present in the diaphysis. Now, this is something which is a metaphyseal lesion. Okay, so look at the region. You look at it. This is not the epiphysis. Okay, so once the epiphysis is ruled out, again your giant cell tumor is ruled out, because though it is not very classical, some people may mistake it for a soap bubble kind of appearance. Because similarly, it will be seen unless you look, very closely. You have to go and look at the X-ray properly. Then you will identify that this is not actually a lesion like that. So grossly, if you look at it, this is a lesion which is found in the metaphysis. So where is the location? The location is going to be in the metaphysis. So what is ruled out? Epiphyseal lesion of giant cell tumor is ruled out. And again, because there is no projection, you are ruling out an osteochondroma. And again, diaphysis, osteoid osteoma will be the lesion. So that is also ruled out. So by ruling out itself, by knowing the gross features, you can get the diagnosis here. The answer is going to be an enchondroma. And the management for this particular patient will be observation. Now, enchondromas are usually benign lesions which do not need any kind of further treatment for many cases. Enchondroma. So cartilaginous lesions, when you look at it, when you think about a cartilaginous lesion, where this one will be present usually in the appendicular skeleton with an intact cortex. All of this is applicable here. If you look at the lesion here, you can see that has got an intact cortex. The cortex is completely maintained. It will come under the category where you have your Enneking latent type. This is your Enneking latent type of lesion. So when you have an Enneking latent type of lesion with an intact cortex, this points to the diagnosis of an enchondroma, which can be serially followed up in the absence of risk factors. Now, this is a proliferation of your hyaline cartilage. This is a proliferation of your hyaline cartilage happens in the metaphysis. So this is a lesion which is present in the metaphysis happening in the appendicular skeleton. It's not in the axial skeleton. It's a hyaline cartilage proliferation. So in the absence of risk factors, you can follow it up. Most common in the hands and feet. Mostly it is incidentally detected. I actually had a patient last year who was a doctor's mother, who was evaluated for some vague bony pain, not particularly in this area. That was her X-ray that I put up here, and then we had a lot of discussion. And we didn't even do a biopsy finally. We decided to keep it under observation because radiologically it was very classical. There is no kind of lesion which is looking significant. So we decided to put her in observation, and still she's on follow-up only. So this is a classical enchondroma. Now, enchondromas by themselves are predominantly benign. On the other hand, when you take it up as multiple enchondromas, that is where the problem will start. This multiple enchondromatosis is known as your Olliers disease. In association with hemangiomas or angiomas of the soft tissue, that is known as Maffucci syndrome. Both of these conditions will have a risk of chondrosarcoma of almost 20%, and it is almost universal as far as the Maffucci syndrome is concerned. Okay, so there is a very high chance of sarcoma, chondrosarcoma transformation. So there you will need to manage it aggressively. So management is just observation and serial monitoring. In Olliers disease, there is a risk of malignant transformation. So there we'll have to manage it aggressively and go for resection of the lesion. Now, aggressive appearance of lesions, how it will look like, that will be your chondrosarcoma. Now you can see that this is your femur chondrosarcoma, which has got a more aggressive appearance. You can see the corresponding, you can see the X-ray picture where it has come out till the cortex. There is some irregularity in the cortex here and there. You can see it is bulging out of the cortex. This kind of aggressive picture is going to be present in your femur, in your chondrosarcoma, and here on an MRI you can correlate where it is coming out. On the other hand, in the phalanx, this kind of lesion what you are having is your benign enchondromas of the phalanx. So location of the lesion, the type of behavior, both of these will indicate to you what kind of lesion is going to be present as far as the bony sarcomas are concerned. And this particular type called enchondroma is one of the benign lesions. But when it is present as a multiple thing, then it becomes a significant problem for you. Now, again, when you consider the other benign cartilage forming lesions, you have got your exostosis, the picture which I do sometime back. You get a lesion, it starts in the near the metaphysis. So you can see that it is arising from there as a pedunculated lesion, usually with a star. And one point will be the actual size of the lesion will be so big on palpation. Why? Because of the cartilage cap. You will have a cartilage cap. The bony lesion will be only so much. And the medullary cavity will continue inside the lesion. Okay, so it is a hamartoma of the bone. It's a cartilage cap projection. That is why the cartilage capping cannot be seen on a plain X-ray. The medullary component will be continuous with the bone. So all of this will be something that will clearly indicate that it is a exostosis or an osteochondroma. It's not an enchondroma. It is called as an osteochondroma. Now, this is associated with these three genes with an autosomal dominant form of inheritance. Classically, the growth with age will be away from the joint, that is towards the diaphysis. It will be away from the joint towards the diaphysis. That is another classical feature that you will find. Now, hereditary multiple exostosis, as like your multiple enchondromas, will have a risk of malignant transformation. And even otherwise, there is a chance of malignancy in the 1%. Is the chance of malignancy in an exostosis. So generally speaking, it is better to excise a exostosis. It is not observed. Usually, it is managed by excision. So here again, you can see in an MRI that it is stopping short here in the medullary cavity. But here you can see the cartilage cap is going to be a little bigger. That is how your cartilage cap will look like as far as the exostosis is going to be concerned. Now, chondroblastoma. So in the cartilage forming tumors, we saw about enchondroma, which is a metaphyseal confined lesion, usually very benign, just needs observation. The other one is a metaphyseal lesion which grows out, continues with the medullary cavity and has a cartilage cap, which is known as an osteochondroma or exostosis. And in both of them, the multiple variants, like multiple exostosis has a risk of 10 to 30% malignancy, and multiple enchondromas, either Maffucci or Olliers syndrome, will also have a risk of around 10 to 30% chance of malignancy, 10 to 20% or more of malignancy. The third lesion that we talk about is your chondroblastoma. Now, among the cartilaginous lesions, this is something which will be classically found in a, excuse me, my friends, just 1 minute. Sorry about that. That was a hospital call which I had to take. So yes, now going on to the actual discussion. So we talked about your exostosis or your osteochondroma. Then we talked about your enchondroma. Both of them are basically your metaphyseal lesions, usually benign and under follow. Now you consider one epiphyseal lesion. This is an epiphyseal cartilage producing tumor that is going to be your chondroblastoma. It is a benign cartilage producing tumor, usually in the bones of children. Most common in the periarticular knee area, periarticular perinea area. That is where you will get it. Classically, this is the picture that you will have, lesion, and usually associated with severe pain, inflammation. It is a symptomatic lesion. So there will be a lytic lesion which will be seen. An MRI will identify the lesion as an intense inflammatory response. Usually needs management for, we cannot leave it just like that. So then we talk about the bony lesions. Now, when we talk about the bony lesions, the typical bone forming lesion is something called as an osteoid osteoma. Osteoid osteoma. Now, how do you identify an osteoid osteoma? One thing is it will usually happen in the diaphysis. Okay, this will usually happen in the diaphysis. This is one of the diaphyseal lesion. You can see it will happen along the long bone. So diaphyseal lesion, and you will see the central nidus. You can see here that there is a dot and the surrounding lytic area kind of thing is there. And classically, you will have a small bone forming lesion, but very, very painful, especially with night pain, which will be resolved by giving aspirin or other NSAIDs. So that is a characteristic feature of your osteoid osteoma. And X-ray will show the presence of a reaction with the nidus. Commonest site is going to be in the femur. Now, the same osteoid osteoma, if you get it size which is more than 2 centimeter, commonly in the spine, as you can make it out here, you can see the nidus here, and surrounding that you can see the lytic component as well. So that is known as your osteoblastoma. Osteoid osteoma and osteoblastoma are going to be pretty similar. So a large osteoid osteoma, usually in the spine, more than 2 centimeters, what will be called as a osteoblastoma. For both, the management is essentially an RF ablation. Okay, under guidance, under image guidance, you will do an RF ablation. Here you can see that that is what is happening. The radiofrequency probe and biopsy, that probe has been put there, and where the tumor is close to vital structures, where your radiofrequency energy may damage the vital structures, there you will plan for your surgery. Otherwise, the management is usually an RF guided ablation of the lesion, which will provide cure for the lesion, and more often than not is successful. They may give you the histology as well. This kind of picture with your typical nidus and that kind of thing can be seen here. So that is another kind of way you can make out the diagnosis. It may come as a image-based question. So this is all very classical findings. You may get your, lesions like osteoid osteoma, osteoblastomas. Then you may get your chondroblastoma. All these are very classical findings. So X-rays, they are very fond of asking. X-rays or other images, they are very fond of asking. So any of these or a clinical scenario may be given to you. It will be usually a classical scenario as far as bones are concerned. Now, the next ones that we need to be known about are the simple bone cysts. Now, these are just serous cavity-filled cystic lesions covered by a membrane that lie inside the bone. Okay. Most common, as I already said, is in the proximal long bones of children, and they may resolve with conservative. Usually, they will resolve with conservative management. Now, a little more aggressive lesion is what is known as your this. Here you can see clearly a lesion which will be present at the proximal end of the long bones in children. And classically, you can see that there is no other abnormal area which is looking there. It is just following the what you can say as the cortex. There is no breach of the cortex anywhere which is happening here. So that kind of picture when you have, then you know that it is a simple bone cyst. And aneurysmal bone cyst, on the other hand, will show fluid levels on an MRI, which is very suggestive. This is basically, instead of containing serous fluid like in a simple bone cyst, it will be filled with blood-filled spaces with multiple septa, fluid levels on MRI, like what we can see here. You can see the multiple areas where some areas are appearing hypointense, some areas are appearing hyperintense. You can see some septa. All of these are features that will be seen in aneurysmal bone cyst. They are generally more aggressive lesions, pain, swelling, all of this will be present, and they will cause fractures, and they may cause an opening of the physis as well. All of this are going to be present. Aneurysmal bone cyst always needs surgery. Almost always we prefer to operate, because many of the time the mimic is going to be there for a giant cell tumor. Okay, so giant cell tumor and aneurysmal bone cyst will look pretty similar. So a lot of times in an aneurysmal bone cyst, if you have a doubt, you will generally tend to operate. At least you will do a biopsy for the lesion. Now this is the next tumor that we are discussing here. So what is this? This is your classical giant cell tumor. You can see the typical soap bubble appearance, what we call as the soap bubble appearance here. And like your chondroblastoma, which we already discussed, this is again chondroblastoma, clear cell chondrocytoma. Like this, in that group, you have your giant cell tumor, which is also an epiphyseal region. So among the epiphyseal tumors, the first diagnosis that will come to your mind is going to be your giant cell tumor. So here you can classically see the soap bubble appearance, multiple thin septa are going to be there, like appearance of bubbles which are collected together. So that's why it's called as the soap bubble appearance. Now, in your soap bubble appearance, what is going to be the management? Is it going to be an intralesional excision? Now, we had a discussion in sarcomas. What is an intralesional excision? And then you have the pseudocapsule where you will have a marginal excision, then you have a wide excision, and then you have your compartmental resection or radical resections and amputations. Now, in tumors, generally we know that we have to go for a wide excision. So, is it always needed though? So, here, is it going to be no? We know that the diagnosis is giant cell tumor. Is it aneurysmal bone cyst? Like unlikely. So, it does not look like that is the diagnosis. This is almost characteristic. You don't find any fluid levels here. So, I think here you can go with the diagnosis of a giant cell tumor. So, osteosarcoma, again, it is a metaphyseal lesion. It's not an epiphyseal lesion like what you're seeing here. So, these two are older. So, the options are either wide excision or an intralesional excision. Now, remember, because giant cell tumor is an what we can call as a aggressive type of lesion only, but it is still a benign condition, intralesional excision is the standard of care. So classical soap bubble appearance, epiphyseal lesion confirm the diagnosis of giant cell tumor. Management is typically by an intralesional excision, and then you do curettage. It is not just enough to remove the lesion alone. So intralesionally, you will go, basically you will put a bony window, you will scoop out all the contents, and then you will kind of do curettage. Initial thing is curettage, basically take out the tumor completely. Then the next thing is to do a high-speed burr. Now, burr is something like this. For people who are not used to orthopedics, it will be something like this, like a polyp kind of thing with multiple, there's an iron thing which will be stuck to the, your motor, and then you will use it. So this will be your burr. So this will be used in the bony surface to upgrade it, basically to make it smooth. So any remnant cells which are going to be present inside the bone at the base, all of them will be taken out. So this high-speed burr is mandatory in today's world in the management of giant cell tumors. The next thing is, along with that, you can use other adjuvant therapy, either heat or cold. What do you use for heat? You use your PMMA or your bone cement, polymethyl methacrylate, which is your bone cement. That is what you will use. So once you have done the high-speed burr, then you will put the bone cement there, which will again, by the action of exothermic reaction, it will generate a lot of heat and will destroy the rest of the cells. The other thing we can use is something called as a liquid nitrogen, freezing it. Instead of destroying the cells by heat, you destroy it by cold at, usually at minus 80 degrees, we'll be using it. Minus 80 degrees centigrade, it will be used. Liquid nitrogen, it will be brought inside a flask, and then it will be put in that area. You have to protect the surrounding structures, because if it falls on muscle or cartilage and things like that, then it can be quite toxic to them because of the extreme low degree of temperature. This procedure is called as the Markov procedure. Okay, it's called as the Markov's procedure, where you use, intralesional curettage, and then you follow it up by liquid nitrogen. Okay, when you use nitrogen for that, that is known as the Marco's procedure for the management of your giant cell tumor. This is what is commonly done in your Adyar Cancer Institute. Nowadays, of course, many people are preferring the high-speed burr, okay, or a sandwich therapy also. They will use a high-speed burr. They can then put liquid nitrogen, clear it out, then add the bone cement. Multiple combinations are used. Now, this is the most aggressive benign bony tumor. Among the bony tumors, this is the most aggressive lesion and commonly happens in the epiphysis. This constitutes around 20% of all the benign bony tumors overall. It may be associated with subchondral fractures and permeative margins. You can see that that is margins which are expanding outside. So that kind of permeative margins can be seen. Now, one drug which will be used, this has been a question that has been asked, unresectable giant cell tumor, because of whatever reason, if the tumor is found to be unresectable, may result in an amputation where it is not really required. Such cases, you can manage them by giving denosumab. You can manage them by giving denosumab as an anti-rankle agent, which gives a pretty good control. Long-term use of denosumab over a period of even 1 year, 2 years, like that, and all people have tried, and generally it gives good results. The other thing you have to remember is there is a small proportion, though it is only a locally aggressive lesion, around 1 to 2% of cases will present with lung metastasis, where you can do a complete metastastectomy with a good prognosis. So, though rare, it can cause lung metastasis as well. Though it's a benign tumor, it can cause lung metastasis as well, and that will have a good prognosis. Right. Now going on to the miscellaneous bony tumor. Here, these are all just some things that I have added. Most of these do not come in the examinations, but I have just added some points that will come. Now, eosinophilic granuloma is an entity that will happen in younger children usually. It is a group of this Langhans cells lesion. So here you have one is unifocal, which is eosinophilic granuloma. Multifocal is Hand-Schiller-Christian disease. And then you have your disseminated with your leprous Seaway disease. So these are the three types of your eosinophilic granuloma. They are commonly present in the diaphysis. This is one more lesion which will be present in the diaphysis of the long bones and also in the skull as well. In spine, it can cause collapse, which is known as your vertebra plana. In spine, it can cause collapse and cause vertebra plana. So it will be similar to Ewing sarcoma appearance on your radiology. On radiology, it can look similar to your Ewing sarcoma. Okay, so that is something that you have to remember. And fibrous dysplasia is a benign developmental fibro-osseous lesions. Monostotic, polyostotic happens in the long bones, rib, skull, everywhere it can happen. So hip fractures will produce the shepherd tooth deformity. This kind of thing what you're getting here. Hello? Isn't it? 1 second. Now you can see the screen. Sorry, it stopped about 4-5 minutes ago. Are you able to see the screen now? Okay, I'll just put up this one as well. Yeah, 4-5 minutes ago. Yeah. So essentially, what I was talking about was some of the benign lesions here. So here we talked about the giant cell tumors where you do an intralesional excision. The classical soap bubble appearance is going to be present here. Multiple septate lesions can be seen, but thin septa which will be there. There, the plan of resection will be an intralesional excision. The plan of excision will be an intralesional excision as far as all the giant cell tumors are concerned. That is the preferred modality of therapy, intralesional excision and curettage. Then you use a high-speed burr. Okay, I showed the diagram of a burr where it is going to be like this. You're going to have a rounded tip like this attached to a micromotor, and with this burr, you can just clear out the base of the tumor. So you use a high-speed burr. Then you can use other adjuvants like liquid nitrogen, which will be used in something called as the Marco's procedure. Okay, you will use something called as the liquid nitrogen in your Marco's procedure, and then you will have your PMMA, which is the exothermic reaction acid, argon, phenol, all these argon photobeam laser, phenol, all these can be used. Now, giant cell tumors are the aggressive benign bony tumors commonly happening in the epiphysis, can be associated with your permeative margins and the subchondral fractures. Now, When you have an unresectable giant cell tumor, in such cases, you can use denosumab as the only treatment for such cases. You can use denosumab and keep them under control for even 1 to 2 years with a long waiting period. You can still continue with that. Very rarely you will have 1 to 2% chance of lung metastasis where resection can be done with a good prognosis, where resection can be still done with a good prognosis for giant cell tumors. Now, Bisnath bony tumors, here I have just put it up as a picture. The presentation like this may be given in terms of a giant cell, it will be present like an Ewing sarcoma. So, shoulder, perishoulder area, skull, diaphysis of long bones, these are the presentations. So, here you will have the neoplasm arising from the Langerhans cells, which is the eosinophilic granuloma. Unifocal is eosinophilic. Multifocal lesions are known as the Hand-Schiller-Christian disease. And you have the disseminated, which is known as the literal Seaway disease. This is one of the differentials for your Ewing sarcoma. When you take up the fibrous dysplasia, it will lead to basically a picture of hip fracture, which will cause something called as a shepherd's crook abnormality. A shepherd's crook abnormality will be found here, where you can see that it's looking like a shepherd's crook. Shepherd's crook is nothing but a stick which shepherds will carry. It will be like this, like this kind of stick kind of appearance is what you are getting in the X-ray. So this is known as your shepherd's crook deformity. And the ground glass appearance with the cystic change. You can see here, this is the ground glass appearance. This is a cystic change kind of lesion, which is seen. So all these are possible in your fibrous dysplasia. So classification of surgical margins is something which we already discussed in soft tissue sarcomas. Intralesional is through the tumor, classically used in your giant cell tumor. All the malignancies, the minimum thing you'll go for is a wide resection outside the reactive zone or the pseudocapsule of the tumor. Okay, so outside the pseudocapsule of the tumor, at least go 1 centimeter margin. In sarcomas, you go at least 2 centimeters margin as far as the bony sarcomas are concerned. Okay, as far as bone sarcomas are concerned, at least 2 centimeters. Some people will even say 5 centimeter margin as far as bony sarcomas are concerned. Radical is, of course, the whole compartment or amputation may be required, and marginal is something which is done through the pseudocapsule of the tumor. Now, most common primary bony sarcoma, and which is the second most common location, we all know that the most common, whenever you hear the word most common, look at whether it's primary or secondary, whether it's a sarcoma or lesion, which is mentioned here. So now this is a primary bony sarcoma. So myeloma is ruled out. It's not a malignancy that they have asked us myeloma. So these two are ruled out. So is it osteosarcoma of proximal tibia or distal femur? Now we know the question asked is second most common. It's now the most common location. The most common location is the distal femur. This is the most common location of your osteosarcoma. Proximal tibia is the second most common location. This one is your second most common location. So osteosarcoma of the proximal femur is the most common location, right? So most common malignancies are secondaries, usually from breast, then by prostate and other sites. Metastasis again spine, especially the lumbar spine, followed by the proximal femur and the proximal humerus. Primary bony malignancy is myeloma, usually happens in the skull and in the spine as well. Primary sarcoma, if you look at it, is osteosarcoma. Secondary arises in Paget's disease. Metastasis in children are from neuroblastoma and then rhabdomyosarcoma. So osteosarcoma, as we already talked about, it's the malignant bone-forming tumor. Now, most of the tumors, malignant tumors, are classified by the presence of the malignant cells, and then based on the matrix. Matrix is the surroundings or substance that surrounds the malignant cells. Now, this, if it is bone-forming matrix, then it is called as a osteosarcoma. If it is a cartilage-forming substance, then it is known as a chondrosarcoma. So, matrix has to be there, made of bone secreting matrix has to be there, and the appearance of malignant features in the cells should be there. So, neoplastic osteoid matrix should be present. As I already said, it's a bimodal age distribution in the teens and in the late 50s to 60s. So here it will be the secondary osteosarcoma, which will commonly happen. Secondary osteosarcoma will happen. Here it will be the primary osteosarcoma. Li-Fraumeni syndrome, again you will have most common sarcoma is going to be a osteosarcoma as far as Li-Fraumeni syndrome. This we already discussed. And similarly in retinoblastoma also you will get your hereditary osteosarcoma. Secondary can happen in Paget's and in the post-RT scenarios. So non-metastatic extremity osteosarcomas. So when you talk about sarcomas, what is going to be the main management of osteosarcoma? In today's world, it is almost always NACT. You will plan, then you will plan for a prosthesis. Now this prosthesis in today's world is something called as a modular processes. What do you mean by this modular processes? It is basically mix and match. Suppose you got the lesion in the femur. Okay, so here you got your great trochanter, lesser trochanter kind of lesion. You got it expanded. So you got a lesion in the distal femur. So you take it off. Once you have taken it off, you want to replace it. So you can decide on the stem length, how much of this length you want, this width what you want, this kind of thing, size what you want. So you can component this component, this one which will be separate. Okay, so here you will have a component which will be separate. Then you will have another component which will be separate here. The size can be changed. So this kind of thing is what is known as a modular process. So the size, basically a mix and match approach you can do. So that kind of process is called as a modular processes. On the other hand, if you do not have the mix and match approach, that is where you will call it as a CMP or your custom made. When you say it is custom made, it is for one particular person. So basically, when you are going to a shop to stitch, so you go for a custom made shirt. So the same way custom made is meant only for you, for your dimensions. So the same way a process is designed based on the length of the lesion, depending on the width of the lesion, depending on the planned excision and all that. That is known as your custom made processes. And these are also called as custom made mega processes because of the large size which is required. So they are called as the custom made process or the custom made mega processes. Now, when you are giving neoadjuvant chemotherapy, there is one factor that you look for in the final specimen, whether there is more than 90% chemotherapy-induced necrosis, because the survival is hugely different. When there is more than 90%, there is almost 80 to 90% survival at 5 years, whereas if it is less than 90%, then only 30% survival can be seen in some patients, especially in the pelvic regions. So this kind of picture is what is needed. So the management of osteosarcomas is initially you treat the patient by neoadjuvant chemotherapy, then you put them to surgery by doing the custom-made mega process or by using the modular processes. You look for the response. If it is more than 90% necrosis, then usually they will have a survival of more than 90% at 5 years. Now, in osteosarcoma, there is some less aggressive variant which is known as your perosteal osteosarcoma, which is a low-grade surface osteosarcoma. It is a low-grade surface osteosarcoma. When you talk about the various types of lesions, some of the special types of osteosarcoma which are going to be there, you have your perosteal osteosarcoma, which is a low-grade surface osteosarcoma. This is your definition. You can see that it is just arising from the surface, not seemingly going inside the bone. See, this is your classical osteosarcoma where you have the Codman's triangle, which is a periosteal reaction. You can see the bone, you can see the periosteum. This triangle which is formed because of that is known as the Codman's triangle. That is a feature that you will get, Codman's triangle, along with the lytic lesion happening in the metaphysis of the bone. So all these are features to suggest it's in osteosarcoma. Here it's both intracortical and extracortical. Both are seen. You can see the Codman's triangle. You can see the destructive lesion. All this is seen. On the other hand, this particular thing that and will have generally a good prognosis. Here again, surgery will be the preferred modality. We may not go for chemotherapy in such cases. If the report is suggestive of a perosteal osteosarcoma, usually we'll go for surgery first and then we may add on adjuvant therapy only if it is needed. The next common primary bony sarcoma is going to be your Ewing's sarcoma. Now, in Ewing's sarcoma, what is the classical appearance that you will have? One thing is it is found in the diaphysis. One of the classical diaphyseal tumor is going to be your Ewing's sarcoma. Then if you look at this one closely, you can see the onion peel appearance. You can see clearly the onion peel appearance. You can see multiple layers because of areas of formation, areas of growth stoppage, areas of formation, areas of growth stoppage. That is the reason why you get this onion peel appearance. So this classical onion peel kind of appearance on X-ray which you get is present in your Ewing's sarcoma. The same Ewing sarcoma in the soft tissue is known as the PNET, peripheral neuroectodermal tumor, or PNET, peripheral neuroectodermal or PNET. So the same thing in bone is Ewing's, extraskeletal Ewing's is known as your PNET or peripheral neuroectodermal tumor. Now, Askins tumor is another entity. Askins tumor is another entity which is the PNET arising specifically from the chest wall area. Now, classically, we know about the 1122 translocation, EWS and FLI1. which is present in 80-85% of cases. There are other things also which will be present. Now, one more thing is, as we discussed in sarcomas itself, these are explicitly sensitive to chemotherapy and also to radiation. Remember, osteosarcomas are usually not sensitive to radiation. On the other hand, Ewing sarcoma is going to be sensitive to both chemotherapy and to radiation. So the management is always at least 9 weeks of therapy. 9 weeks of therapy has to be given with chemotherapy. The regimen which will be used is something called as a VAC and IE regimen. Alternative weeks of VAC regimen with IE regimen. That is the classical, chemotherapy that will be used for your Ewing sarcoma. And then after 9 cycles are completed, then you can plan for surgery. Now, in critical areas, like for example, in the spine, sometimes in the skull and things like that, you can even treat them by radiation. Radiation will also work well for these tumors. So in critical areas, you can even plan for radiation for these tumors. These group comes under the small blue round cell tumor, and one of the features that you will find is the Humorite pseudorosette. So this is you can see that these are the small blue round cell, and here you can see that they are forming rosettes, like it's a bunch of flowers with, a central area, and then you got a, surrounding area which is filled by this one. Why is it called as a pseudo rosette? Now, pseudo rosette is something where you do not have a central vascular core. On the other hand, in the same tumor, if you have a central vascular core which is going to be present, then that becomes a Humorite rosette. Okay, so in your Ewing's and peanut, you will get a Humorite pseudo rosette where there is going to be no central vascular core. It will be just a soft tissue core that will be seen there, not a vascular core that you will be seeing, not a blood vessel that you will be seeing. So this picture can be given to you, the small blue round cell, uniform cells. They may ask you a combination of factors, a 6-year-old girl, presence with a tumor, this is the X-ray appearance. Then you have this kind of picture. They will show you the pseudorosette. Here also you can see that there is a pseudorosette which is found here. So that kind of picture they may give you and they may ask you. Today's world, they are asking a lot of clinical based and correlative questions. So just be prepared. Remember all these factors, then you will find it easy to answer the question. Right. Now going on to the primary cartilage producing sarcoma, which is your chondrosarcoma. This is a cartilage producing malignancy. So location is important in prognosis. As I already said, pelvic sarcomas will have a poor prognosis. The same thing in digits, if you take it, it will be even called as a chondroblastoma. It will be called as a chondroblastoma even. So instead of saying it's a chondrosarcoma, they may even call it as a chondroblastoma. So where the location is, that is going to be a very important factor in deciding. So in your pelvis in general, it will have a poor prognosis. In pelvis, they will have a poor prognosis. In digits, it may even be called as a chondroblastoma because it may not have a very poor prognosis. It may be even called as a chondroblastoma. Secondaries, as we already saw in Maffucci syndrome and in multiple exostosis, it can arise from it, but it's a rare thing. Usually, it is a primary chondrosarcoma. Clear cell, this is another entity which we already discussed. Clear cell chondrosarcoma is something that will be arising from the epiphysis. Clear cell is going to be something that arises from the epiphysis. As far as the clear cell chondrosarcoma is going to be concerned, it arises from the epiphysis. And one more thing is, this is something which will be usually chemosensitive as well. Clear cell chondrosarcoma is going to be something which will be chemosensitive as well. Okay, clear cell chondrosarcoma is also something that will be chemosensitive. Now, when we talk about the management of bony sarcomas, we already discussed that all of them will need some form of initial chemotherapy. It is usually NACT and then surgery. In chondrosarcoma, there is no role for chemotherapy. In chondrosarcoma, it is straight away going to be surgery, which is the treatment option. Okay. In Ewing's and osteosarcoma, it is NACT and then followed by surgery. The preferred modality of surgery is your limb salvage surgery. It is the norm. Reconstruction with either the modular or the custom-made makeup prosthesis. So amputation and survival, amputation and limb salvage surgery, there is no difference in survival. Now, when you have a lesion which is involving, so you will talk about a limb which is known as a dead limb or a dead loss. So when you say a dead limb, basically the vascularity is going to be compromised. On the other hand, dead loss is basically when you have a neurological thing which is completely compromised, which cannot be reconstructed. So when any of these two is going to be present, you can consider a amputation. But even in this cases, you have other modes which are known as, one is your Vaness rotation plasty and the other one is called as your Turner plasty. So this is used usually in the pediatric age group where you have a growing skeleton. So in the pediatric age group, such patients, suppose you got a tumor, you can plan for a resection of the tumor And after that, the distal femur will be turned up and it will be, so distal fibula along with the blood supply will be retained, and this will be turned up and fixed to the femur here. As you can see here, the fibula has been turned and it has been fixed back here. So this is known as your turnoplasty. On the other hand, you just remove the joint. You have removed the joint in this particular area, and then you use the ankle joint like the knee. You know, the knee is equal to the ankle here. The ankle joint has been made into the knee joint. So this one will give you a very easy and a good movement as far as the process is concerned. But remember, Van Ness rotation plasty, though functionally it is very good, cosmesis is very poor. Cosmesis is very, very poor as far as Van Ness rotation plasty is concerned. So that is the reason counseling is very much needed. There have been documented cases where the kids have even attempted suicide after undergoing a Van Ness rotation plasty because of the very bizarre appearance that you get after this. It's a functionally good procedure, but it can be looking very, very bizarre. You can see here that it is there and is fitted with the process nicely. It will work, but you know, it can be very, very mentally demanding on the patient till they get used to it. Okay. So then chondrosarcoma, as I already said, is insensitive to radiation and chemotherapy except for the clear cell, myxoid and clear cell variants, it is called as. So myxoid clear cell variant of chondrosarcoma will respond to chemotherapy. All other variants are going to be kind of like it is not useful. Chemotherapy and radiation are not useful, where surgery is the only modality. So when you talk about bony metastasis, which is the true statement here, best survival is seen with renal tumor metastasis. Most common cause of bony metastasis is osteoblastic breast metastasis. Most common location of bony metastasis seen in the thoracic spine. Prophylactic fixation score, Merrill score is greater than or equal to 8. So let's look at each option as a whole. Renal tumors do have a good prognosis, but the best prognosis is seen with thyroid metastasis. When you consider metastasis, the thyroid metastasis that will have a very good prognosis. The same way, the most common location is the osteolytic. Okay, we know that it is breast metastasis, but it's osteolytic. If you look at the question I had mentioned as osteoblastic, it is actually the osteolytic breast metastasis, and that will happen to the lumbar spine, not to the thoracic spine. So Merrill score is something which is used for metastasis, whether to go for prophylactic fixation or not. So this is based on whether it's the axial or the appendicular skeleton, weight-bearing, non-weight-bearing area, type of lesion, whether it's mixed, lytic or blastic pattern, less than 1/3, more than 1/3, less than 1/3, 1/3 to 2/3, or more third of the circumference of the weight-bearing area. So this will basically give a clue on whether you need to fix it. Now, there are a lot of lesions where it can be a lytic lesion without any fracture. So do you need to plan for fixation? That is what your Merrill score gives. Now, score of 9 or more needs fixation. This is the classical thing. Bailey, they have given us greater than or equal to 8. The classical, first paper that was published by Merrill says score of 9 or more needs fixation. 8 is surgeon decision, and 7 or less need not have any fixation. In Bailey, it is given as greater than or equal to 8. So we will go with that as the option. Greater than or equal to 8 needs a fixation. And this is the Merrill scoring system. So upper limb has a low score, lower limb has a higher score, and peritrochanteric has the highest score of fractures. The same way, pain, mild, moderate, and severe. Then you have less than 1/3, 1/3 to 2/3, and more than 2/3, and lytic, plastic, and mixed. So this is how you group it. And anything which is equal to greater than or equal to 8, you get a score in the Merrill scoring system. Then you have to plan for your prophylactic fixation. Right. So RCC, whenever you talk about metastasis, generally we talk about a palliative therapy, but there are a lot of scenarios where it can be potentially a curative therapy. For example, renal cell carcinoma, breast carcinomas, thyroid, it's not mentioned here, but thyroid metastasis, melanoma with isolated metastasis, all these, it is a curative resection, and replacement also has to be considered. So when you have multiple lesions, you have to consider usage of bisphosphonates and denosumab, which is an anti-rankle ligand, to reduce the skeletal related events. The best agent, as I already mentioned, is denosumab. Most economical agent is bisphosphonates. In this, again, this question has been asked multiple times. It's Zometa or zolitonic acid. The dose is 4 mg injection given every 3 monthly. Current standard of care is given once in every 3 months. That is the dosage which will be preferred. Now, there are something called as radiopharmaceuticals. Okay, there are something called as radiopharmaceuticals. When the patient has got severe bone pain, then you can use these radiopharmaceuticals like strontium 90 and samarium 153. Okay, strontium 90 and samarium 153. These are two radiopharmaceuticals which can be used. Preferred is usually the strontium 90. The strontium 90 is the preferred radiopharmaceutical which will give a very, very effective control of your bone pain. Now, prosthesis can be used, it can be epiphyseal, especially in metaphyseal lesions. You may plan for a resection and reconstruction as well. When it is a diaphyseal lesion, you will prefer not a resection, you will prefer a intramedullary. We talked about that in the picture. No? When we had a lesion in the femur, IM nailing through the greater trochanter will be the preferred modality. And the hip, usually you prefer a total hip replacement because you can replace the entire socket, ball and socket of both the sides. That will give a much better functional result as far as the hip is concerned. And that ends the session on sarcomas, my friend. And there is just the cutaneous chapter which is left, which I'll be taking on tomorrow. I'll be taking it tomorrow. Probably we can have a session at, I'll update it later tonight. Okay, I'll just put up a message within the 1 hour. I need to find out my other schedule at the hospital and then I'll update you. So we will have the session tomorrow and we'll try to complete most of the session, which is going to be the most of the topics which are there. Only cutaneous remains, melanomas and non-melanomas. We'll try to finish it as one particular session. So thank you.